We are online now.
Hi guys, thanks for joining. This is Essence of Medicine. Today we're going to be talking about, are all MIS surgeries really minimally invasive? I'm Amanda Armagost.
My name is Alyssa Haber.
And I'm Dr. Abbasi for Essence. And today is my pleasure to introduce to you my big brother, my partner, and a very experienced spine surgeon, Dr. Sunny Kim, who is an orthopedic surgeon, fellowship trained with more than 30 years experience in managing most complex spine surgery, spine situation, including scoliosis. Today is a special day because as well I invited another Dr. Kim, Dr. Hanjo Kim from the special hospital in New York. It was a short notice. I don't see him joining us. We sent him the link. And the idea is here to talk about spine surgery. The joke in the spine management is that you give 5 surgeons one case, you come back with 7 different opinions, and that's unfortunately true. Now, there are lots of talk about the minimally invasive spine surgery, and obviously everybody like to call whatever they do spine surgery, they call it minimally invasive. And Dr. Kim and I, we are doing something what we call transcameral OLIF procedure, oblique lateral lumbar and the body fusion. And I'm going to, the format of this procedure, of this podcast is going to be that we are going together listen to Dr. Hanjo Kim's presentation and discuss it in an academic sense. But more or less, Sunny, why don't you introduce yourself? What qualifies you to have an opinion on the spine?
Okay, so I was, I prided myself as a maximally invasive spine surgeon, doing pedicle subtraction, osteotomies, big, huge, massive scoliosis cases, deformities, big open surgeries. Everything was open my first 20 years of my career. Then I started migrating into, more minimally invasive, spine surgeries relying on X-rays and imaging, etc. So for the last 10 years of my career, I have become, that has been the trend, more minimally invasive spine surgeon. Okay.
Before we begin, I want to ask, is there a strict definition for minimally invasive when it comes to surgery?
Well, I think a minimally invasive, the word is a kind of catchword for, very little blood loss, short anesthesia time, less tissue destruction, for performing accomplishing the same goal as the open surgery.
And colloquially, or I should say maybe jokingly, that if I do it, it's minimally invasive. If you do it, it's not minimally invasive, because everybody likes to call what they do minimally invasive, even it's just very little different than an open traditional surgery. So the definition is not really unified. Let's put it at least that way.
But let me quote an example in heart surgery. In the beginning, heart surgeons were doing coronary artery bypass surgery by doing a big incision and using a saw to cut the sternum and enter the chest. And it used to take 4 hours put triple coronary bypass surgery. They were taking 4 hours using cardiopulmonary bypass. Now the cardiologists are doing it probably in about half an hour without taking any incision through using catheters and needles.
Okay.
So that stent procedure qualifies as a minimally invasive, as opposed to the old-fashioned, big incision coronary artery bypass surgery. So spine surgery is similar.
Good to know.
Now, Sunny, tell me a little about your education, about your cases, kind of cases you're doing, and tell me a little about your volume, because I want the people who listen to this conversation know that this is not you didn't just start doing this. This has been going on. I'm trying to record this as well on my live feed on TikTok. So why don't you tell me a little about, especially, you're a very prolific scoliosis surgeon, both pediatric and adult. Mm-hmm. Tell me a little about your training and your volume of this kind of procedures, and specifically about I think something that's very important about indication for the surgeries that you're going to talk about, please.
Okay, so in the beginning, I was a deformity trained spine surgeon. So my fellowship after finishing orthopedic surgery residency at Columbia University in New York City, I did an additional year of fellowship doing, pediatric and adult spinal deformities, including scoliosis. And so that's what I did first 20 years. And so everything was open. Everything was, big, long incisions and a lot of bleeding, cauterization, and closing these cases will take up to an hour because incisions are so long, and you gotta, close the wound in triple layers with, significant risk to the patient due to bleeding and high infection rate, 2 to 5%. I'm talking about instrumented spinal fusion.
Yeah.
So that's what I've done first 20 years of my career, and that's what was being done at that point.
So you're familiar with the material that we are going to watch by Dr. Hanjo Kim inherently. This is what you live every day in and out, correct?
Correct.
And I think the viewer know me from lots of different presentation podcasts that I have done regarding the OLIF procedure. So I'm not a scoliosis surgeon, but especially I don't do the juvenile scoliosis or pediatric scoliosis. But along the way, I have been very severely involved in the management of degenerative scoliosis, but I use the minimally invasive OLIF technique for that. So, and I have published 11 papers about this procedure and how it's done, and so on. So I do consider myself well qualified to do these comments. Now, let's just jump to it. Okay, let's just go to it. And I'm going to share my screen now. And guys, you are welcome always to ask questions, because probably any question you ask, many other people will have the same kind of question for us. And so feel free to just ask any question you may have, okay?
Okay.
So here, I'm going to start. Are you able to see my screen?
Yep.
Okay, so let's start. Now, I would say I run it in segments, then we stop and we comment on that. This is, by the way, a very good presentation that visualize the stand of the MIS versus open surgery for this complex kind of surgery. So let's start.
How we can make surgery better and faster for our patients, whether it be MIS or open. Here are my disclosures. So one thing I want to say is, I know I've given a few talks here to this conference about how MIS techniques are not really superior to open techniques, but I just wanted to let you know that I'm not necessarily against MIS surgery. So I think there are times when MIS surgery could be helpful. This is a patient of mine, 61-year-old, who had an isthmic spondy that was symptomatic with leg pain, failed conservative measures for management. So you can see there he's got a lysis at 5'1", nerve compression. So I did a lift followed by percutaneous screws for this guy. I used the Augmented system so that you minimize fluoro time. Just one spin with the Zeem after you place your post. And you can see here on the time, for when I started instrumenting with the incision 121, and then my last screw, the fourth screw, was placed by 138. So I think this is value added. Surgery is you don't have to do the midline dissection. You get the indirect decompression of the foramen with the A-lift. And when you go posterior with a system such as this, you're not taking a ton of fluoro shots going back and forth. Everything's done with this Augmented system, and I have no disclosures regarding Augmetics. I'm not a consultant for them or anything, but I've done this case with Augmetics now about 3 times. And the fact that I could put 4 screws in with just percutaneous percutaneous incisions in pretty much 17 minutes is pretty good. Probably will get faster as my learning curve gets better. When I go to my 4th, 5th case, but I think this is value added. And this is some of the ways that this works intraoperatively. It actually works pretty well. And one thing I like about it is when you have the headset on, you look at the spine as if it's already completely dissected out. So when I even find my starting points, I'm not really using this little thing. I'm using my starting points as if I was at an open spine. And then I check with this axial and lateral sort of vision they give me to confirm. But a lot of the times I'm just placing the screws where my normal starting points would be. I think where MIS starts to get into problems is when you have.
So let's start actually right here, Sonny. What I hear that he just started using this MIS guided technique. And one of the things I learned, if somebody says to something and say, but, everything they say before but is really not what the message is. Everything they say after the but is the message. He says that, I have nothing against the MIS, but my message is that it's not, and it's going to come that it's not there. No, first of all, he's using augmented reality, navigation, so on and so on for this procedure. I'm going to tell you my experience with the navigation, but why don't you use navigation, Sonny? Well, do you need navigation to perform at the level you're performing?
I don't need a navigation because I use, C-arm, and some of the hospitals I work out of, they don't even have a navigation. So what are you supposed to? What if you're in a third world country, for example, somewhere in Africa? They don't have a navigation.
Sonny, I disagree with you. You do use navigation. Your navigation is between your ears.
Yeah. I mean, that's a surgeon's, but I don't use any fancy $1 million, computer system.
I would say your navigation system is very fancy. And you have a robot. You have 2 robots attached to your shoulders. And I've seen your results, and you are more efficient. The reason, so people who know my background, they know I did a PhD in computer science and surgical navigation. The reason I don't use it is not because I don't like them. I love them. I mean, if you come to my office, it's made of computers and so on and so forth. But the day they would be advantageous to my patient is the way I'm going to use them. In the time they bring those machines in, you and I are done with the surgery. And that's the absolute fact to it. Now, I'm sure Dr. Hanjo Kim is a very experienced surgeon, and he's just getting involved in the surgical navigation with augmented reality and so on. But one of the surgical navigation that I think is the most effective way of doing the surgery is double C-arm. Then you get those pictures, you put it in your brain, in your computer, which is the best in the universe together. You create a 3D picture, and then you see at every moment in real time, the tip of your instrument. Most of the navigation or MIS, what they call MIS these days, use a spin with a CT-like machine, and then they register it in the OR. Obviously, that takes time. And then they use a wand or a probe to identify the tip of the instrument. But let's listen to him. Any other comment here, Sonny or Amanda and Alyssa? Do you guys have any comment regarding this?
I have a comment brewing, but I'm not ready yet. So we'll
Okay,
keep-
so this was just the foreplay. Let's listen to him.
Have cases like this. You have multi-level fusions, and you have to ask yourself, just like Greg had shown very appropriately, some really great cases that were done through MIS. It's impressive that you could do 7, 8 level fusions with MIS and get the results that he's getting, but it's not very practical. And like I had.
So he says it's not very practical. And another thing he says is that not everybody is like the person who did that. I totally disagree with that it's not practical, because we are doing it every day, Sonny. And another thing he says that, not everybody has that level of experience, but that would as well apply to open surgery, that not everybody is like Dr. Hanjo Kim that can do those surgeries that efficiently. So would you have any comments regarding the practical, being this kind of MIS surgery being practical or not? What do you think, Sonny?
Well, no, the MIS surgery using bilateral or 2 C-arms can be accomplished for multiple level lumbar fusions.
Yeah.
And I guess it's all a matter of what a surgeon's experience.
Yeah. Now, he has this paper here that he's presenting. He's going to explain it more, but he's looking at that for comparing this open surgery, MIS, robotic, and he's going to come back to that and look at the numbers there. And especially, he underlines the operative time and post-operative complication and so on and so forth. And that is something there I totally agree with. Look at the complication with the robot.
Mm-hmm.
Are you able to see that, Sonny?
Mm-hmm.
Those, especially, what I see a lot today, that because industry is pushing for that, they're trying to replace the skill of the surgeon with a robot. Look at the complication rate, double. And what that means is that, I agree with him, robot, they're just not good yet. And I think replacing surgeon skill with a robot is a really disservice. Now, robot can be additional tool in the hand of a well-skilled surgeon. But that is what's happening, what I have a lot of problem with. Trying to replace surgeon skills with a robot, I think that just can end up in catastrophe. Do you know why? Because I wrote those algorithms. I know what their limitations are. I know that they are really not what you want them to be. But as well, Sonny, look at the times there. The operative time, I'm not sure that is what they refer to. That I'm assuming they are in minutes, like 234 minutes, which is like what? Almost 4.5 hours, right?
Right.
Almost 4 hours, and then I think 325 is significantly higher with the MIS and robot. Is it your experience that the MIS is longer than open, Sonny?
MIS should be much shorter operating time. The MIS surgery that we do is about 5 times shorter than open surgery.
And I like you said that 5 times.
Or magnitude shorter.
Yeah, magnitude. Yeah, and I think you're not much exaggerating, depending on who does the surgery. These are the average time, and we have 10 years of data. We have published that.
Putting a cardiac stent, it is order of magnitude faster than open heart surgery in old-fashioned way.
Because you don't have to open the damn sternum.
In the time you spend closing the incision, you've done the surgery skin to skin. We don't have to spend any time closing the incision, the portals.
No, and we have a data regarding that in average, after 15 cases, that one level surgeries falls below 1 hour with a transcaminal. You need as well to tell that the surgery that we do is a transcaminal where we utilize the cambing triangle, and we use a tube. We don't open it up. We don't bring a big machine in and spin. We use 2 C-arm, and we use a less than an inch, half an inch incision on the left flank. We go with the tube inside of the disc, take the content of the disc out without cutting. We dilate it, and then put a spacer, and then we do percutaneous screws. So in average, for us, takes less than 40 minutes to do that. And I've watched your results. You do even sometimes 2-level fusion in 1 hour. So this number definitely do not apply to us. Now, I remember one day, about a few years back, you came to me and you told that you're so happy because it is 3 o'clock and you're done with all your surgeries, with the open surgery. Do you remember that? You told me, yes, you're so happy you're done with the surgery. Otherwise, you would have been until 7, 8 p.m. in the hospital. So these numbers, even though they apply to this procedure in the hand of people who published this, by the way, I see one of the publishers here, his name is Hamid as well, no relationship. Okay, so, but in average, our 1-level fusion is under 1 hour, our 2-level fusion is maybe 1 hour and 15 or 20 minutes, and we regularly do 3-level fusion in 1.5 hours to 2 hours. That is a routine for us.
What about the blood loss? I'm noticing with Open saying that there's less blood loss than MIS.
No, that is as well a little, I think, I'm looking at that, the ODI operative time. Where do you see the, estimated blood loss?
Mm-hmm.
That it's not less than open surgeries, if anything is more. And I can just tell you, we have the published data. Our blood loss is 1/10 of open surgery. In most of the time, it's just few spoon of blood. We don't use even suction or anything. We weigh the sponges before and after. That is how we measure the blood loss. So,
and length of stay. Do you see length of stay is also longer for MIS?
These are, Sonny, what you should comment on all of this. What do you think about this kind of MIS compared to what we consider MIS?
It's order of magnitude. We are more minimally invasive in terms of operating time, blood loss, length of stay, etc. So it's a different animal. We're talking about apples and oranges here.
Yeah, we are not talking about the same thing. So let me put our numbers in, okay? And our numbers are operative time, if they are referring to 1-level fusion, is 47 minutes. That's our average. Our estimated blood loss is per level about 52 cc, so 1/10 of what they put here. And our length of stay is in average 1.6 days. So almost 1/3 of what they have here. And then the levels fused, they call it two-level fusions. And the revision, the numbers, I don't have that number, but it seems to be as well for us somewhere between 1% and 3%. But that number we can look up. The other numbers are no for sure. And the complication rate is definitely less than the 5 to 8%. If you put all those different kind of complication, especially like our risk of infection is 0.2%, whereas average risk of infection for open surgery is sometimes 3 to 5%. Risk of durotomy for open surgery is 8.7%. Ours is 0. And we have nerve root irritation, but all of that is temporarily in our paper. The long-term 1-year nerve root irritation rate was 0.3%. So, and that risk is for open surgery as well, 1 to 3%. So, Sonny, help me out here, but I don't believe any of those numbers is realistic for our minimally invasive surgery. What would you say?
Well, I think what they're calling MIS surgery in that table 2 is dramatically different from, our MIS surgery, the transcambian olive. So,
and that is sort of, if you put all the MIS together, like bunch us with the groups that have that result, I agree, we are probably not better. If that's what they refer to MIS.
Yeah,
But-
it seems like maybe we could have been an outlier or something like that and just got completely skipped from this chart, because also I'm looking at BMI and
Mhm.
you guys consistently do very high BMI patients.
Yeah,
This
our
is
average BMI that of the patient that we treat is the 38 actually, 10 point higher than that. But there is a reason for that. Sunny, why do you think we treat more patients with higher BMI?
I think many of the high BMI patients we treat, they are declared inoperable
Or other surgeons?
by technique other than what we are doing. We can do much higher BMI patients using the transcambient technique, even BMI up to 60. My record is a BMI of 68.
Yeah,
And you
I can-
cannot do open surgery on BMI 68 patient.
and I can guarantee you there are very, very few people who are willing to give the patient that choice. And you are just reciting the data. This is a paper we published that shows that whereas TLIF and even MIS TLIF don't perform very well in higher BMI, literally OLIF stays flat. And look at that, even that paper, our paper, which is 400 patients from one of the major hospitals in Minneapolis, shows that at BMI of 37, as Dr. Hanjo Kim reports, it becomes lengthier. The reason this MIS start lower than regular surgery is actually because this surgeon has done over 2,500 MIS TLIF, MIS surgeries, so he's very efficient. Otherwise, for most of surgeons, actually Dr. Hanjo Kim is right, that MIS start above this and the surgery becomes more dangerous and lengthier. Whereas look at our OLIF. Not only we are way below open surgery and what they call MIS, but we can keep that advantage in higher BMI. Multiple other papers have confirmed this result for us. Let's listen to Dr. Hanjo Kim a little more.
I mentioned in my prior talks, we have to follow the literature because not every single MIS deformity surgeon out there is Greg Mundis. And if you look at what the literature shows us trying to incorporate some of the MIS technologies into even regular lumbar spine fusions, we have to ask ourselves, are we doing better for our patients? And is this something in a cost-conscious environment that is becoming increasingly more cost-conscious? Is this something that we are doing in a responsible way and an accountable way as spine surgeons? So here, good data demonstrating basically open surgery is the cheapest and probably the best and fastest way to do the surgery right now with the way technology stands.
So let's talk about that.
Can you go back to that slide?
Absolutely. So
where is open less expensive than MIS?
Right there.
well, here, look at that. If they called open surgery $42,000 and MIS total a little maybe less, but robot total $60,000.
That big of difference.
But it's still.
Now, you remember Dr. Kim was talking about the $1 million machine that not everybody has. And I think that becomes even more important. If you go back and see the robotic complications are twice as much as regular surgery. Now, in what universe, he's right there. In what universe makes sense to spend 50% more and have twice more complication? And the surgery is as well longer and so on and so forth. What he talks about the robotic and the MIS in the fashion that he presented robotic and MIS, it's right. But I think my problem with that is that he bunched all the MIS together and thinks just because those people call this MIS, that applies to all MIS. Now, regarding the cost of the surgery, Sunny, first of all, any comment here?
Well, I think robot definitely add $20,000 more of resources, and without a whole lot of advantage there. okay, on the previous slide, table 2. So what's the benefit of using robots? Maybe it's the, more impressive to say that you're using robotics to do the spine surgery.
Yeah, like a gimmick, like a marketing gimmick.
Yes, exactly. Yeah.
But my problem with that is it's more expensive, and you saw the rate of complication. That is twice as much. Now, my answer to that, to the economic, is the first paper we published regarding the olive, transcambing olive, was an economic paper from here. We have the date of the publication from 2015. And we showed that actually the surgery, the hardware itself is the same price, but it actually saved money to the healthcare system. And
Because you got shorter operating time and the shorter length of stay.
exactly. And less risk of infection as well. The combination of less time in the ward, less hospital stay, and less complication actually tremendously saves money to health economy. So I have no choice but completely disagree that MIS is actually more expensive. And if you want to be cost conscious, you have to go to the direction of the MIS, but you have to choose your MIS. Not every car is the same. You cannot compare Mercedes with a Tata. So if you put them all, call them just cars, then certainly you're not talking about the actual performance of each individual procedure. Now, what is your understanding, or what is your experience with patients' discharge, Sunny? You have been doing it now for so many years, and you have a huge amount of experience with the transcambing olive. Compared to the open surgery, what is your experience on the patient's discharge and hospital stay, which is the main factor in the cost related to a
there's a huge difference between the transcambing approach and the, so-called conventional, T-lift technique. Half of the patients actually done as an outpatient. They go home the same day.
And even multi-levels.
Exactly. And I just did a full level. The patient went home the next day, which is unheard of. Full level lumbar fusion for L2 to S1. I used to keep those patients in the hospital for 10 days, and they ended up in a nursing home. They go home the next day, straight home, which is unheard of. So there's no comparison. There's no real competition between this transcambing and conventional either T-lift or A-lift techniques.
I agree.
Think about the cost added, like once they have to go to the nursing home, that's an additional cost that they wouldn't be having at home.
That's correct.
But as well, there are so lots of adjacent costs, like when they go home, the daughter has to take time off, come and help them, whereas our patients are independent. And we have a very nice graph that shows 96% of our patients are independent within first 24 hours after the surgery. That's why they can go home. 96% of our patients go home within the first 24 hours. Our average hospital stay is 1.6 days. By the way, these data are recorded by state of Minnesota. These are public information. Connect to us. We are happy to provide you the reference to that, because in the state of Minnesota, every hospital reports for every CPT code of the surgery, the average hospital stay. Whereas in Minnesota, it is about 4 days, and in some hospitals, 7 days. Our average hospital stay in the hospital that only we do spine surgery is in 1.6 days. So this calculation for hospital stay and the cost of the surgery does not really apply to all MIS. So should we keep listening to that, Joachim?
Fastest way to do the surgery right now with the way technology stands. And
he said open surgery is the fastest way to perform this kind of surgery. And with fastest, he means more efficient. And I understand, and I totally agree. Efficiency in the surgery is a very important factor. But what is your comment that the way he does the surgery is the fastest and the most efficient way of doing the surgery, Sonny? What do you think?
Well, I mean, I think he's not including our procedure in his talk.
Yeah.
That I think that's the issue there. I mean, if our procedure was listed there, it will win hands down.
Yeah.
All categories.
Now, what we need to emphasize here that we are not just talking based on our gut feeling. We have 10 years data for all the numbers that we are presenting. And if somebody is interested, connect to us. We show you the data. We have published 11 papers, but as well, we have lots of data in our database that backs up the numbers we are presenting.
And this is some of our own internal experience, like I had shown previously, but for deformity operations, the length of stay is shorter for open surgery. You may use a little bit more instrumentation for an additional level or two when you're doing an all posterior approach without all those all the inner body work. But the surgical time is significantly less. You get the patient on and off the table much better, much more.
So he says he used a little more instrumentation. We had a study, and when we went to a new hospital, the hospitals do something called value-based purchasing. They look at how much your instrumentation cost and compare to what else they have. And when they did that, it was practically no different between the transcameral OLF and the TLF in the cost. So that is already done. But he says patients stay shorter and the time of the surgery is shorter. And I guess we talked about that in both of our hands, Sonny, both of these statements are not correct. Do you have any comment?
Yeah, again, our procedure is not a part of the what's in his list.
Yeah.
That's the reason.
More quickly, and then the cost, despite the use of 2 large kits of BMP for a typical T10 to pelvis operation, you can see here the cost is about 30% less. And that's not including the savings in the length of stay and the savings in the operative time. If you could do 2 T10 to pelvises in a day as opposed to 1 because you're doing a hybrid or a deformity approach.
So I like what he says about the efficiency in the OR. He says if you can do 2 surgeries versus 1, that is beneficial to everybody. How many surgeries do we do, Sonny, in a day? Big surgeries, multi-level, 4-level fusions.
We can do up to several, maybe 4, up to 4.
Yeah, and we do regularly 4 and sometimes up to 6 large fusions. If they give us 2 rooms, we can go back and forth. I have done up to 6 and 7. But in 1 room, we can easily do 4. So what he considered, the efficiency, meaning doing 2 of those surgeries, we already doubled that in our daily practice. So, but I agree with him. Some surgeons say efficiency, speed in the OR doesn't matter. He's right. Efficiency and speed in the OR does matter. But he's comparing himself to wrong MIS surgery. Any comment or question regarding this before I start playing more of the presentation?
Nope.
You're economically doing better, and so is the hospital. And you're doing more throughput, and you're doing more cases, and your volume is higher. So that's something to consider. Now, let's look at what happens with MIS operations and how fast you can really get in regards to screw placement. So the learning curve is high. You start out at 6 to 8 minutes a screw, but then eventually, by the time you're at your 65th case, you're approaching 2 to 4 minutes per screw. Question is, if you're doing a construct like this, where if you have it open, you could really, I'm not speeding this video up, by the way, this is just my flow, 30 seconds a screw versus on average 3 minutes a screw for a robotics case. If you're doing an 18 screw construct, you're already losing 45 minutes of time. And I think you could say you could make up.
So Sonny, any comment on the efficiency of pedicle screw placement? Because I know you do as well these big surgeries you can comment on that more regarding, now, one of his critique is that the open surgery is more efficient. And but what do you think about the
Well,
learning curve and
I
efficiency?
think once you have it open, but you got to get to that point. So the prep time is much longer. Through MIS screws, there's not much prep time. You just go right away and do it. I think I can put a pedicle screw in, perk screw in maybe in 30 seconds.
I know you can. I have watched you doing that.
Yeah, but that doesn't involve opening and closing. So, let's again compare apples to apples. If you don't have to close and open, I mean,
Well,
it's dramatically faster to put a perk screw in. I mean, once it's open, I mean, I use the same technique. I use a battery operated drill and the free-handed, and you can put that in really quick. But you have to get to that point. So he's got the wound there exposed. It's going to take at least a half hour to expose that much.
now, we made a science out of it. Now, he has his own learning curve, which I want to show you one more time, which he says it takes them 50 to 60 cases for them to become efficient. And we showed that with double C-arm, that is actually much faster. You need 20 cases to become really efficient. It seems that the efficiency double C-arm make your learning curve so much faster than whatever the technique they are using with the robotic. And it makes sense. With double C-arm, you see the end position of each instrument in real time, and you use your brain as neuronavigation machine that helps you truly become really efficient. And with that double C-arm, with our technique, contrary to with the robotic and so on, and that is the reason I don't use robotic, I put a pedicle screw in 30 seconds as well, and I don't have to open it and close it. And I have seen you doing that. So that does not, this again, does not apply to what we do. So let's
Question is, if you're doing a construct like this, where if you have it open, you could really, I'm not speeding this video up, by the way, this is just my flow. 30 seconds a screw versus on average 3 minutes a screw for a robotics case. If you're doing an 18 screw construct, you're already losing 45 minutes of time. And I think you could say you could make up for that on exposure, but an exposure like this really takes 15, 20 minutes. And closure, I think, is the same because you're trying to close tiny little wounds. And a lot of the times you're not really getting good fascial closure. And
so he just added that you added the 40 minutes more to the surgery, but you add as well, then you add as well 20 minutes to opening and 20 minutes to closing. But as well, I can tell you, there are very few people who can open this in 20 minutes and close it in 20 minutes. I know you can do it, Sonny. I've seen you that you're very efficient, but he uses actually his metrics and transfer it. He thinks everybody can open and close in 20 minutes. I have done a lot of open surgeries and I'm very efficient at open and closing, and I know you are. But what do you think in average, opening that area, not for you, I know you open it in 20 minutes as well, but I have seen surgeons struggling 2 hours to have that opening. Now bleeding, you have to stop the bleeding, but as well, I think what's more important is equating the infection rate of that opening to MIS. What do you think about the times that he's reciting and everything that goes with that, Sonny? What do you think?
Well, I think thoracic spine is much easier, but it's much more shallow.
Yeah.
If you talk about lumbar spine is deeper because of lordosis, so it takes longer time.
Definitely.
Also dependent on the BMI of the patient. Higher BMI takes, much longer to expose.
Yeah, we didn't even talk about the higher BMI. But, considering that, what do you think about that 20-minute opening, 20-minute closing? And because you have seen a lot of different surgeons, not every surgeon open that in 20 minutes, right?
Right. You have to be very experienced to accomplish that in 20 minutes.
Yeah. Whereas we have shown, independent from your situation, if you take the closing and opening away, this learning curve is the same for almost every surgeon that we have brought in and we have investigated that. After 20 to 40 cases, they become really, really efficient. Most of our surgeons, they come to us, they finish a 1-level fusion under 1 hour after 20 cases. So let's listen to him. We have a few minutes more left.
And that could be questioned, but I think you could save on exposure, but at the end of the day, you're still losing. And I think that has to be considered before you start to really try to integrate some of these other techniques for screw placement and helping or integrating technology into these parts of the operation. The radiation exposure is real, and I'm going to go through this again, but a 5 times higher risk of breast and uterine cancer in your patients that are getting multiple spins or multi-level fusions. So you notice that I say,
so this is important, and it is a real concern. But there is a caveat here, okay? So look at this. When you look at this paper, what is the most important? Amanda and Alyssa, when you look at this paper, what's the most important thing about this paper?
I mean, in fact, that's 25 years old.
25 years later.
25 years later, yeah.
So meaning that somebody has gathered this data for 25 years. This study started probably 10 years before that. So the machines, the X-ray machine that they use are machines that 5 years before that they bought it are 40 years old. Now, if somebody's interested, I have actually a blog, my neurosurgery case review blog. I have an album that makes the calculation for you. So, Alyssa, what do you think? What are the different, or Sunny, both of you, what do you think? What's the difference between an X-ray machine or C-arms that are 40 years old versus C-arm that is 5 years old or 10 years old? What is the difference?
The amount of radiation that's needed to get the image that we need nowadays. They've had the ability to advance that technology.
Bingo.
Yeah.
Bingo. Now, and I think that sort of really sums it up, that the machines that are used today, they use much less radiation. As a matter of fact, 1/200th of the radiation. And I have done that calculation in my neurosurgery case blog, Radiation the Science. But this is a real concern. But considering that people who do the other MIS, and he talked about that, they do multiple CT in the OR, like 4 or 5 CT in the OR. The idea here is that with the new machines that these days we use, if you are 6 feet away from the machine, officially, you don't even need to use a lead apron, because the amount of the radiation they use is so little, and they electronically, they amplify it and so on. So again, right information, but doesn't apply. So let's listen to him more. Sunny, you have a huge radiation concern, and they're all real. What do you think about the radiation? I know that you even use these special gloves and so on, and the special goggles and so on. Tell us about that. What are your techniques to reduce the radiation?
My technique is try to step away when you push the button. So you got to be, several feet away. It drops off with the square to the distance.
As a matter of fact, if you are 3 feet away, you get 10% of the radiation. That's the physics of it. Okay, so if you are 6 feet away, you don't need a lead apron. You can stay there at the corner of the room without lead, and that is absolutely fine with the radiation physics of it. So
multiple spins. If you're doing one OR spin, O-arm spin, or a Zine spin for your navigation, for your technology that you want to integrate, or 2, maybe 3-level fusions, that's fine. But when you start to do 3, 4 scans because you're doing a T10 to pelvis construct and you really want to see and be able to navigate the upper and lower part, I think you're really starting to push the limits on what you're doing and the risks that you're exposing your patients to, yourself to, as well as your surgical team. And like I showed you before, the average if you look at what the radiation difference is, it's really quite significant. It's basically like me asking another surgeon who uses navigation for every single case and scanning every single case to also have about 2,000 more CT scans of the lumbar spine when I'm just going to be sitting in a lead protected environment. So here's a typical case that I do, just open and just with or without interbody, depending on the level of decompression that's necessary. And I'll show you what this results in. This is a very recent case. This is the actual operative note. So you see you're just under 4 hours from skin to skin time. So maybe 3 hours and 40 minutes, 3 hours and 20 minutes. And the blood loss is 400. They're not getting transfused post-operatively. And their discharge summary, you can see here, is 3 days. So 3 days in the hospital, less than 4 hour surgical time, 400 cc blood loss. I think if you try to do this case MIS, the likelihood is that you may stage it, so the length of stay gets longer. But even if you don't, the length of stay might be similar, maybe a little higher. But the operative time is definitely going to be higher. And the radiation dose that you've exposed yourself to and your patient to is also definitely higher. So we have to make it make sense. If we're going to integrate technology into the way that we operate, we have to do it in the way that it helps. And I think MIS deformity surgery should probably be stuck to open type of surgeries. It's like trying to fit a square peg into a circular hole. And at the end of the day, we can't compromise workflow or efficiency, because that's more time in your pocket to be home with your families, to be home and doing the things that you like to do outside of spine surgery. And I would tend to support that if you're going to do a 3-level operation or more, open is likely better, less radiation, faster OR times with more predictable results and alignment outcomes. Thank you.
So opening the closing remarks, and I'm going to just unshare the screen. Now we can, talk about the opening, final kind of information that he provided to us. Funny, what do you think about less radiation? Okay, if they do 5 spins, yes, but we measured our radiation, we get 1.5 minute total, 90-second radiation for 1 level. That's our average for 1 level OLIF. Faster OR time wrong by a magnitude, and predictable results and alignment. So what do you think?
We are again, what Dr. Hanjo Kim is talking about as MIS is totally different from what our MIS is, order of magnitude difference. So we are talking about different techniques here.
Yeah, so not
actually his MIS, the highlight of his paper is that MIS surgery does not necessarily provide any advantage over the conventional open surgery, and it's cheaper, more expensive without any advantages. But again, he's not talking about transcambient approach.
Yeah. So in a way,
there.
So in a way,
his MIS means using robotics, put the screws in, and that type of thing, using gadgets to put the screws in. And it's still the same open heart surgery. His MIS is still the same open heart surgery. It's not a stent procedure we are doing.
Yeah,
kind of procedure. We are doing the stent procedure, just like we are becoming like a cardiologist of spine surgery.
Yeah. You know what he says with other words? He didn't mean to say that, but no MIS or open surgery hold up the way we do the surgery, you and I, Sonny. He just proved to us with his numbers and with number that we have, he proved to us you and I are so far ahead of the curve that all those people who say they do MIS, when they are compared with the open surgery, they are no better.
There is also, just sorry for the interruption, but there's also further cost saving with the MIS surgery that we do, because it's a truly MIS procedure without any tissue disruption. We are preventing future surgery, adjacent level breakdown.
Yeah.
If you add that cost, we're even saving more money, because we are making future surgery less frequent.
And not to mention, Dr. Bassi really emphasizes, with the minimally invasive, you have the less infection, the less tissue damage, the less muscle breakdown, which then has less recovery time, less PT, less pain, all this stuff that comes along with that backup visits, all those extra little bits and pieces. So it's not even just, it's a lot of thinking long term for these patients too.
Sonny, absolutely, Alyssa. But as well, the whole team, we just compared our results to Dr. Hanjo Kim, who is the top surgeon in the world for this kind of procedure. We just looked at his number, a number that everybody else calls MIS, to our number. We are not 5% better. We are by a magnitude, we are twice, 3 times more efficient. We reduce the costs significantly. A hospital stay 1/3, rate of infection 1/15, blood loss 1/10. This is where we are. And with we, I mean anybody who uses this trend can be an approach, because we teach it to everybody and they perform at the same level after a learning curve. So in a way, Sonny, I'm a little proud to listen to this and have a small little smile in my face, because we compared ourselves not to average Joe. We compared ourselves to Dr. Hanjo Kim, the top of the world, Mount Everest of spine, and we are twice as efficient and 3 times better in efficiency in the efficiency parameter than the Mount Everest of the spine. So that makes me feel good, actually. Now, there's a problem there, though. We call that evidence-based medicine. But in truth, that is not evidence-based medicine. It's eminent-based medicine, meaning few people who are on top of their field, like Dr. Hanjo Kim, they talk and everybody just blindly follow them. Now, everybody thinks all MIS are inferior to open surgery just because Dr. Hanjo Kim said that. I have a problem with that. I have a problem with, bunching them all together. And in a climate that really is eminent-based medicine, few eminent people say things. And the consequence of that is they don't discredit just certain kind of MIS, but all kind of that, where we know our procedure. Now, I'm not saying I, as a person, as a surgeon, but our procedure has 1/20th risk of infection and 3 times more efficient, 3 times less hospital stay, and significantly faster recovery. I have problem with eminent person discrediting that, and they practically keep the old ways more leeway.
Well, I think this just reinforces the importance of data collection, publishing papers, research, and so on, because it seems like maybe a lot of the information that he was using is out of date. It's pretty obvious that a lot of it didn't include our procedure, which is done by not only the 2 of you, but other doctors, other places, other countries. So I just think that he has good intentions and it's really great information, but it's not including all the information.
But that's the point. His informations are not out of date, but not complete. I think the problem is not that the result that he presented was from 20 years ago. People still are doing those procedures. Those procedures actually are new, those robotic and so on. But it is like I'm telling you, you have a car and your car has if you have an accident, it's 60% that you die. But Alyssa, you have a Toyota Camry, and Amanda, you have a Ford or you have a Mercedes S-Class, where people don't really die in that. And I say, or vice versa, whatever.
You want me to die. I get it. It's fine.
No. But I'm saying, if I cannot bunch you together and just say, that is the result of that. If I'm going to be honest, academically honest, I have to dissect it. I have to, no, he may say, okay, I didn't know about your transcambinolif. But then my critique on Dr. Hanjo Kim is, you're on top of your field. Why don't you know about this? Like I told you at the beginning of this, Sunny asked me, where did I hear the talk of Dr. Hanjo Kim? I listen to 3 talks every day. And my job is to know everything that is to be known about the spinal fusion and so on, because I'm a specialist in that. So if he may say, okay, I didn't know about your procedure, but we invited him, I sent him an email. He hasn't called back, contacted him back yet. I invited him to this talk. He didn't take the opportunity. The question is that you're an eminent person in the spine. Why don't you know about this?
Yeah, to not include Olaf is kind of doing a disservice to the people who attended, and they're trying to learn, and now they're trying to make decisions on what procedures they should do, and a procedure which is clearly safer for the patient was completely left out.
Yeah, because I'm sure, Sonny, you and I, we know all about all the procedures he talks about. We know all about that, don't we?
That's correct. Our procedure is now well known. It's not.
Yeah. No, but you and I are very knowledgeable about the procedure that he's talking about.
Oh yeah, yes.
But
Because
he's not, obviously, he's not knowledgeable about what you do, about the transcameral lift. He didn't include that there.
That's correct.
And that, I think, that is a problem. That's a problem if an eminent person just is either not knowledgeable or doesn't try to be knowledgeable and dismisses, because it does happen often that, I go to people and tell them, do you want to look at the data? Amanda, you know what they say. If I tell them, you want to come and look at the data, they say we don't have time. So, and that is unbecoming of a profession. Now, we looked over that and we discussed it. Any other comment or anything else you guys want to add?
Yeah, if Dr. Kim wants to come and have a separate conversation or wants to come and learn, he can reach out and that'd be awesome.
You are talking about Dr. Hanjo Kim, not Dr.
Yeah,
Kim.
obviously, yeah.
Dr. Kim is an expert in this. He doesn't need any additional education.
Yeah, I know that.
Well, thank you very much. Thank you, Sonny, for your time.
No problem.
And for Essence, this is Dr. Abbasi.
My name is Alyssa Haber.
I'm Amanda Armagast.
And that is famous Dr. Sonny Kim. I introduced this.